Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to one of our quick sessions in which we summarize together one of the top articles. And today we are going to talk about peripartum cardiomyopathy. I know we have discussed this before, but today during our session we are going to look at this extremely important topic from a different perspective. You know that there is no doubt that cardiac diseases are becoming our main concern as obstetricians in UK now. We are talking about the most common cause of maternal mortality in UK, and unfortunately it continues to be so after many years. Not only that, but also cardiomyopathy has become the main cardiac cause, uh, or the main cardiac condition that cause cardiovascular deaths. This before, guys, was not cardiomyopathy. The main cause was ischemic diseases and arrhythmias. But the latest Embrace report shows that myocardial disease and cardiomyopathy encounter now like 25% of the cardiovascular deaths in UK. So let's get more familiar with this condition. If you know the definition of peripartum cardiomyopathy, you are not going to face much difficulty in recognizing the symptoms, or at least suspect that your patient is in risk or she's having a peripartum cardiomyopathy. First of all, peripartum cardiomyopathy means that you need development of cardiac failure in the last month of pregnancy or within 6 months of delivery. This is very important. The timing will help you a lot to figure out if this is a previous cardiac condition or it's a cardiac condition because of pregnancy, especially if it's accompanied with absence of identifiable cause of cardiac failure, plus absence of recognizable heart disease before the last month of pregnancy. And last but not least, and which is very important in the definition also, left ventricular dysfunction less than 45%. So to diagnose peripartum cardiomyopathy, you need those four criteria. Our college defines peripartum cardiomyopathy as idiopathic cardiomyopathy presenting with heart failure secondary to left ventricular systolic dysfunction towards the end of pregnancy or up to 6 months following delivery with no other cause of heart failure is found. It is a diagnosis of exclusion. And maybe that's why I'm not going to say many doctors is going to overlook it, but many doctors, if they do not have this differential diagnosis in their mind, they are going to miss it. And of course, the left ventricle, for for it to be heart failure, we need ejection fraction below 45. Okay, in the Embrace recommendation, the latest one, they are stressing on the point that you should know what are the red flags are. Red flags mean there are cardiac specific history and suspected heart failure, but you don't know the likely cause, or there is no history of cardiac problem before. So if you have a patient with restlessness when lying down or at rest, unexplained cough, particularly when lying down, or which produce frothy pink sputum, and I think this line came in the last exam in the January part two. If I'm not wrong, it was an EMQ case, and they mentioned that the patient is having breathlessness and she's having coughing when she lie down, and she produce frothy pink sputum. This is a sign for pulmonary congestions, guys. But if there is no history of cardiac abnormality before, this should alert us that this may be peripartum cardiomyopathy. We have also paroxysmal nocturnal dyspnea, being woken from sleep or by coughing, or when she wake up from her bed and improved by moving to an upright position. That means congestive heart failure, right? The patient is feeling suffocating when she lie down, and she feels better when she moves up or upright. And lastly, palpitations. Palpitations is a physiological symptoms in pregnancy, right? But the awareness of persistent fast heart rate at rest is not normal. So you need to ask your patient, are you aware of your heartbeats even at rest? Even if you are just watching TV or holding your phone or something like this, you are just relaxing and you're still aware of your heartbeats. This is very important. Okay, know your enemy. Risk factors are one of the clues that can help you to diagnose this case. Not always, but it can help you. Afro-Caribbean lineage, multiparity, multiple pregnancy, obesity, of course, chronic hypertension, no doubt, preeclampsia, and advanced maternal age. Please don't forget about advanced maternal age, because advanced maternal age not only accompanied with such cardiac condition, but it has many other risk factors for other conditions. But keep it in your mind when you are counseling a patient who is getting pregnant over 40 years. Please keep in your mind that she's very risky for cardiomyopathy. Okay, I'm having a case here, and by the way, this is a real case. Well, it's a real case report, okay, for a white woman. So this is unusual. This is not from our risk factors. She's 29 years. She's not so old. Okay, she came urgently and she has just given birth 5 days ago. She reported dyspnea and fatigue that lasted 2 days ago. She said that because this was her first pregnancy, she saw that her symptoms to be normal after delivery. However, when her husband insisted she went to the clinic for evaluation, she was found to be, this is our first clue, dyspneic, hypoxic, with saturation on room air in the low 80s percentile. Why she's having hypoxia? This is not normal. If dyspnea is normal, this is not normal, and was sent to the emergency department for further treatment and investigation. This patient was obese, but in relatively good health. She had developed gestational hypertension during her pregnancy without preeclampsia. Okay, I will keep it in my mind. She's having dependent peripheral edema, maybe because of the hypertension, I don't know, as well as some symptoms of an upper respiratory infection. So you may think that the dyspnea has something to do with the upper respiratory infection, right? But still, the hypoxia is non-explained. Why she's having hypoxia on room air? She was given labetalol twice daily for blood pressure management, okay? During examination, she noted to be afebrile. So I'm trying now to exclude infection. Blood pressure is not so high, only 156/88. Pulse rate is not tachycardic. Respiratory rate is 20 breaths per minute, tachypnea. Oxygen saturation is 95% when she was on oxygen, 2 liter by nasal cannula. This is definitely pathological. This cannot be physiological by any means. She's having hypoxia even on nasal cannula and oxygen. Okay, what about the examination? Very important. Her lungs were clear to auscultation. Her heart rate was regular. Yes, there is S3 gallop. Extremities were non-edematous. She had no cuff tenderness. And this is very important for part 3. So focus with me that you don't forget to ask about VTE, or we call it cardiovascular complications or thromboembolic complications. We are now in the peripartum area. So we are fearing of what, if you can guess with me, pulmonary embolies from a VTE or something, right? So keep it in your mind, peripartum area, we are talking about high risk for VTE. Okay, and urine analysis was negative. Okay, so we have excluded infection by far. We are having no cuff tenderness and no other signs that can lead us for VTE. but still, I don't know. Should I go on and order like CTPA for her, or VQ scan maybe, because the X-ray came out normal? What about the X-ray? Have they told us about it? Yes, they told us about it. But before that, the plasma levels of D dimer and PNP, huge rise in them. The D dimer is over 1,000, nearly 2,000, and the PNP is 864. Very high level. And the ECG showed normal sinus rhythm. Okay, so now I'm talking about a healthy heart, or no arrhythmias at least, or should I exclude myocardial infarction? Let's see. Chest radiographs showed cardiomegaly with increased vascular congestion bilaterally. Cardiomegaly and increased congestion. Okay, that can be a sequelae of chronic hypertension, but this patient does not have chronic hypertension. She just had gestational hypertension. So it's not that common to have cardiomegaly and increased vascular congestion. This congestive heart. Okay, let's see what else. They had a CT for her for a possible pulmonary emboli. It showed evidence of pleural effusion, cardiomegaly, but no emboli. So up to this level, I'm not going to tell you what else had been done for this case, but I need you to take a moment and think about it and think what else I should offer this patient to make a final diagnosis. What is the most important investigation in this case that will give me a definite diagnosis if this is really cardiomyopathy or something else? I will give you that moment and you can pause the video and think about it. We had done ECG, chest X-ray, and CT. And by the way, CT is not from our basic investigations in UK. But anyway, they did it to exclude the pulmonary emboli. Okay, but we need another one. We need another important investigation to see what's wrong with this heart. Yes, echocardiography. Echocardiography. We need echocardiography immediately to exclude valvular disorders, to exclude any cause, organic cause for heart failure, and to see what about the ejection fraction of this heart. If this heart is going into failure or not. And that's what happened. I'm going to return to the slide again, but that's what happened. They made the echocardiogram and it showed left ventricular ejection fraction less than 45. It was 35 to 40%. With a trace of aortic and mitral regurgitation, which is acceptable with this condition, of course. This is a typical example of new onset peripartum cardiomyopathy. It's a diagnosis of exclusion. It needs a hell of investigations. It needs high level or low threshold of suspicion. Low threshold of suspicion, specifically when the chest is okay. There is no signs of pulmonary emboli, and there is fatigue and dyspnea and hypoxia, even on nasal oxygen. Okay? So let's check the other differential diagnosis for peripartum cardiomyopathy. So if we get back to the differential diagnosis to see what else could be there in this lady, like maybe it's benign dyspnea of pregnancy. She's not pregnant. Maybe arrhythmia. No, arrhythmia is excluded. Maybe amniotic fluid embolism, also excluded. Maybe asthma. No, this is not asthma. Because if you remember, the chest was clear on auscultation. Maybe it's a pre-existing valvular heart disease. There is no history of pre-existent cardiac condition. Maybe it's hypertensive heart disease, as I thought about it in the very beginning. right? But this needs pre-existing severe hypertension, chronic hypertension, not gestational hypertension. We need years of severe hypertension to have cardiomegaly and congestive heart failure and so on. Maybe it's cardiac dysfunction secondary to ischemia. No, the ECG was clear. Pulmonary impulse. No, it was also excluded. So I'm left now with peripartum cardiomyopathy in the postpartum period. Either it's uh, for the unknown cause or the HIV cardiomyopathy. And of course, we will have a history of HIV in this case. Okay, so we need, again, to take full history, whether medical or surgical and obstetrician, of course, and physical examination to exclude any chest disorder or to exclude any organic disorder in the heart, ECG, blood test, PNB is the most important one, and echo. If you can remember, we have talked about the BNB before, and BNB is not only important to diagnose something like peripartum cardiomyopathy, but it also gives us an idea about a woman who is having a cardiac condition, whether she is doing better, or doing worse than before. So the trend of PMB can give us an idea about her cardiac condition. Even preconceptionally, we can depend on PMB to determine the class or the heart condition of this lady before she gets pregnant. Okay, so as a basic investigation, ECG, chest X-ray, echo, BMB, troponin if you suspect ischemia, um, and that's it. Blood gases, of course, and other basic labs. I'm talking about something specific here to help us to diagnose what's going wrong with a patient who is having dyspnea at rest and she's having hypoxia even with nasal cannula. This patient, after having diuretics, the fatigue and dyspnea greatly decreased. And by the way, this is another proof that she's having peripartum cardiomyopathy. Peripartum cardiomyopathy symptoms is going to be much better after treatment, not like other cardiac conditions. She was discharged from the hospital 3 days later and instructed to take lisinopril and labetalol. Follow-up examination at 6 months shows stable cardiomyopathy and well-controlled hypertension. And when we repeated the echocardiogram, it showed improved ejection fraction of 55 to 60%. That's why I'm telling you this is a definite diagnosis for peripartum cardiomyopathy. Okay, I just brought you this from our previous talk summary for this talk article to just remind you what are the pharmacological management for peripartum cardiomyopathy. Anything that can help you deal with the exhaustion of the heart, like diuretics, antihypertensives, anticoagulations. If there is arrhythmia, we can give arrhythmics. I'm sorry. Uh, and they were talking about the usefulness of bromocriptine and whether it can help us to, let's say, control the condition or not. They advise a dose of 2.5 milligram once daily for at least 1 week in uncomplicated cases. So bromocriptine is promising, but it's not given routinely to every case. Only or roughly 5% of peripartum cardiomyopathy patients will need mechanical support or transplant. Those patients are having severe cardiac failure and they are not improving on medication for whatever reason, or maybe They presented very late with having a severe cardiac failure, and that's why they are going to need a mechanical support or transplant. What about labor management? I'm just going to remind you also that in the absence of overt cardiac failure symptoms, we just need supportive medical therapy and spontaneous vaginal delivery. There is no indication for cesarean section in a patient who is having hemodynamic stability. She is asymptomatic. Her NYHA class 1 or 2, she's going to have a normal vaginal delivery. If she needs intramuscular corticosteroids like any other patient, she can need it if we are talking about the preterm birth. It's better to do a 30-degree left tilt to avoid the aortocaval compression. It's much, much better if you can give her a low dose regional analgesia instead of the usual dose of regional anesthesia. Why so? Because you need to avoid hypotension in this lady. You can limit the active phase of second stage of labor, of course, if needed. It's not a must by instrumental delivery. Oxytocin is our friend here for controlling the hemorrhage in the third stage and postpartum hemorrhage. Misoprostol and carboprost can be used, but take care if she's hypertensive or not. And misoprostol have a common side effect, which is shivering, and it can cause hypotension also. Long-acting oxytocin analogs and ergometrin should be avoided because of the risk of heart failure secondary to medication-induced hypertension. I think you all know this. So again, guys, take care of the medication you are going to give this patient during labor. And whether she's having a stable cardiac functions now or not, always balance between the preload and afterload. If she's having a problem with the preload, don't give her much fluids. If she's having a problem with the afterloads, don't give her severe hypotension by neuroaxial anesthesia, because this is going to be lethal for her. Okay. Contraception, of course, we are going to avoid the COCs whatsoever. You are not going to give her any kind of estrogens. What about the IUDs and Mirena? They are really helpful. They are long-acting and they have no added risk for thromboembolism. Even with those ladies with high risk of cardiac arrhythmias, they are totally safe. But you are going to tell her that she needs to come to the hospital for IUD fitting. Why so? Because you know that they may have vasovagal effect during cervical dilatation, and this is not good for them. They don't need prophylactic antibiotics. And if you need any kind of LARCs containing progesterone, it's definitely safe. Think twice before offering your patient female sterilization, because she's going to have anesthesia, and anesthesia is not our friend here. To have the balance between preload and afterload and so on, and maybe she is on anticoagulants and she's going to be at risk for epidural hematoma and so on. So if you can offer her, you can offer her male sterilization, especially if you are talking about someone who is having persistent left ventricular dysfunction. I think I have reached our discussion. Last but not least, try to remember that those are the timings that you need to tell your patient to come for screening echocardiography. If she's having a history of peripartum cardiomyopathy before, so if she gets pregnant again, she will need echocardiography preconception once by the end of first trimester and second trimester, and again 1 month before delivery, once again after delivery, and 1 month after delivery. This is how we are going to follow up her, of course, to know if her heart, cardiac condition is getting worse with pregnancy or not. Okay, guys, please don't miss the red flags. Tachypnea, chest pain, persistent tachycardia, orthopnea. Those are the red flag signs that you should always be fully investigated. Don't overlook them. Don't say that they are physiological adaptations of pregnancy. Most of those patients are awfully missed because they don't have a typical epidemiology. Like as we saw before, she was a white female, she wasn't old, everything was okay with her. Even her obstetric history was not that risky. She was controlled. She had gestational hypertension and she was controlled on labetalol. So please take care of the red flag signs, and thank you so much for being with me here today. And inshallah, I'm going to meet you again very soon.